Plastic, non-inflammatory lesions. So if we think back to that chart that we've been using to help classify cytological samples, we have infection, inflammation, neoplasia, non-neoplastic, non-inflammatory. So this category, and it's hard to say 10 times fast, but it is sort of the miscellaneous category. They don't necessarily fall into any other specific category. So examples of NNNI would be hyperplasia, cystic masses, seromas, epidermal inclusion cysts, follicular cysts or nail bed cysts, mucoceles and salicyles, and hematomas. Hyperplasia is one that you almost most commonly will get under the microscope. And it is normal, i.e., and it is an abundance of cells creating a mass or an abnormality in the skin or the tissue. So it's a little bit tricky to wrap the head around at first. Normal cells, so non-hyperplastic cells, are uniform, and often there's more cytoplasm than the nucleus. So if we're looking at normal, non-hyperplastic, just a regular cellular sample, they're typically uniform and there's more cytoplasm than nucleus. Hyperplastic cells, it's a condition in which there is increase in the number of normal cells in a tissue or organ. Hyperplastic cells have more nucleus than cytoplasm. It can happen as a result of injury or hormone imbalances, and they're often symmetrical. So the thought process on identifying hyperplasia is mainly you're comparing it to normal cells. So is this just, I took a fine needle aspirate and I happen to go through some certain cells, maybe some fibrocytes, etc. And are they just normal fibrocytes that I'm seeing? Or is this an abundance of fibrocytes? Is this hyperplastic fibrocytes? So you're comparing it to normal tissue, and then you're also having to compare it to benign neoplasia, and then also malignant neoplasia. So we've got three categories that we're comparing hyperplasia to. That's why it becomes quite difficult. Main thing, just knowing why hyperplasia occurs. Typically it's a result of an injury or hormone imbalance. And examples would be nodular growths in the prostate, liver, and pancreas. Those are common places for hyperplasia. So if we're breaking it down a notch, and we're going to compare neoplasia to hyperplasia. This is a big wordy slide. Hyperplasia is considered to be a physiological, so normal, response to a specific stimulus, and the cells of a hyperplastic growth remain subject to normal regulatory control mechanisms. So it's a response to a stimulus, and it's subject to normal regulatory control mechanisms. Neoplasia is considered generally abnormal cells proliferating in a non-physiological manner, which is unresponsive to stimuli. So neoplasias are just happening regardless. There doesn't need to be a hormone imbalance, there doesn't need to be trauma or any sort of stimulus to create neoplasia. Hyperplastic proliferation, so growth of hyperplastic cells, is a normal response to another abnormal condition, i.e. an abnormal stimulus perhaps. In contrast to neoplasia, where the growth, the proliferation in itself is abnormal. So that's just, it's to help you understand why hyperplasia is occurring as compared to why neoplasia is occurring. But realistically, we don't necessarily have all this information before we're looking at a cytology sample. So prostatic hyperplasia, this is an example. So normal prostate cells with increased nucleus, they're all uniform, and it's in result of a stimulus. Nodular hyperplasia. And even still, the more common is you might see something like gingival hyperplasia. And if you were to sample the areas of gingival hyperplasia, you're likely to see typical epithelial cells and fibrocytes that are increased in nucleus, increased nuclear to cytoplasmic ratio. So just going back to this, to get this on a slide, there's a big thought process going on. So right away, I would never expect you to look at this and absolutely say, this is a prostatic, because you're not going to be necessarily overly familiar with prostate cells to start with. If you specialize in cytology, you likely will be. And B, this is hyperplasia. We know the common characteristics of hyperplasia, that's what I explained in the slide prior. However, in order to identify hyperplasia compared to benign neoplasia, histopathology would have to be sent out. We can suspect one versus the other, but there are not enough true cytology or cytological differences between benign neoplasia and hyperplasia for the vet tech or for anybody to absolutely confirm, yes, this is hyperplasia as compared to benign neoplasia. So just keep that in mind. That being said, in lab, the expectations will not be for you to identify and diagnose hyperplasia. Heck no, we don't do that. But just to, if we come across hyperplastic samples, just to get an idea of the common characteristics of those cells. So moving away from hyperplasia. Cystic masses are also another non-neoplastic, non-inflammatory sample. They're not just cysts. They're masses that are liquid-filled, but it could also be filled with sebaceous material, dead tissue, cells, etc. So it can be thick, thin, or chunky. Examples of cystic masses, we have seromas, hematomas, epidermal inclusion cyst, i.e. sebaceous cyst, and salivary mucocele or salicele. Seromas you'll commonly find, most often I find seromas occur in an area where something's been removed and a fluid is filling that area from here on out. So oftentimes you might see seromas around surgical incisions or in the scrotum of a dog or a cat, male dog or cat, who's had the testicles removed. And it seems to look like a small swelling. There's no heat to it. It's not necessarily red in color. It's just a small swelling, little pocket. And it's upon evaluation, if we take some sample from it to confirm that it's a seroma, it's a pocket of serum. And it's often post-surgical. The fluid that's removed from it is yellowish to pink gooey fluid, so sticky gooey fluid. And cytologically, you'll see some macrophages, some RBCs, and some healthy neutrophils. That is a seroma. So if you were to take a sample of that because the client's concerned that it's a giant infection developing after surgery, you'd be more likely to see bacteria and an inflammatory response. So we've got some macrophages kicking around, a couple of red blood cells, a fairly low cellularity sample. Epidermal inclusion cysts, my favorite, sebaceous cyst. They're similar to follicular cyst and nail bed cysts. They contain white to yellow to gray, sort of oily, gritty material. The key characteristic of these guys is that when you spread the chunky or gooey material onto a slide with a squash prep, you can feel grittiness between the two slides. That is a key characteristic of an epidermal inclusion cyst. And that's in part due to the breakdown of numerous keratinocytes that are sitting within that inclusion cyst. You'll expect to see some squamous cells, keratin flakes, and lots of cholesterol crystals. If they have ruptured, if the cells have ruptured, the release of keratin can cause a pyogranulomatous, if the sebaceous cyst has ruptured, the release of keratin can cause a pyogranulomatous inflammation. So you could be on the lookout for that. I have a couple of samples where the dog has ruptured their sebaceous cyst either through accidental trauma or self-mutilation, and right away, because of the release of keratin, you can get a pyogranulomatous inflammation. So here's a non-inflammatory follicular cyst, and you tend to get that pinkish, sort of granular, proteinaceous background, lots of anuclear cells kicking around, and it just looks generally debris-filled. Here's a nail bed cyst, so that's more anuclear cells rather than the debris. And here are cholesterol crystals, really common to find with sebaceous cysts. So MUCOCELE is an enlargement of a hollow organ or sac that is filling with mucus. Delish. Also known as a salicele, it's a salivary gland cyst that's filled with mucoid saliva. So a salicele or salicele is specific to salivary gland swelling. Usually it's from a ruptured salivary duct, and when a fine needle aspirate is performed, a gooey yellow-pink fluid is removed. That being said, saliceles can look very similar to swollen submandibular lymph nodes. So a lot of people jump the gun, get very worried right off the hop that perhaps the animal is showing signs of lymphoma or reactive lymph nodes, etc., or activated lymph nodes. So don't jump the gun if you see swollen submandibular lymph nodes. Don't forget, always check the other peripheral lymph nodes, see if there's generalized swelling or if it's localized, because that can help give more information as to the cause. And then ideally a fine needle aspirate would be performed, and if it's this pink yellow fluid that's kind of sticky and gooey, it's more likely to be headed in the salicele direction. So again, it's a blocked salivary duct. In the cytology, you'll normally find macrophages, neutrophils, and red blood cells. You might see hematoidin crystals or hemosiderin granules, and the background is often pink, sort of like a cloudy pink. And this is pretty common. So here are some macrophages specific to mucus. Remember, I was telling you in previous lectures how when macrophages are in mucus, they become very frothy and very vacuolated. Okay, and then large pink clouds of keratinized tissue, some red blood cells, and then there is some breakdown of RBCs right there. Here's another good example. So this is common finding on a salicele. Okay, hematoma. Hematoma is a pocket or a collection of blood outside the blood vessels, commonly seen on the pinna. Now we also cause hematomas sometimes in our blood withdrawal technique if we don't put pressure on the opened vein immediately after removing the needle, then we can cause a little hematoma, i.e. a bruise. So it's blood escaping vessels. On the pinna, it's called an oral hematoma, and it's typically, you see it in animals who have had itchy ears, whether it's an ear infection or inflammation of the ear that's chronic, and they've been scratching the heck out of it or shaking their head excessively, and while they're doing that, they're loosening up the connective tissue between the pinna and the cartilage of the ear, or sorry, the skin of the pinna and the cartilage of the pinna of the ear, and they're opening that up, they're tearing that away, and it's creating a large pocket. When that happens, the small blood vessels get ruptured, and then they'll start to fill that open space with blood, as is what fluids do. They will find an open space and fill it. The fluid will look a lot like frank blood, and you'll expect to see macrophages. You won't see platelets unless there's fresh bleeding, and you'll see hematoidin and or hemosiderin granules. Treatment of oral hematomas should technically be surgical in general, and there are various techniques. Some people will use a punch biopsy and sort of make the inside of the pinna look like Swiss cheese, and that so it can drain, and then they tack down the skin to the cartilage of the pinna so that it maintains in its spot. Other people sew buttons to the ears, and that's to prevent the sutures from rupturing when the animal shakes its head, but also tack down the pinna to, or the skin to the cartilage. Here's an oral hematoma. Some people, to relieve the animal, especially if there are financial concerns, they might simply lance the oral hematoma. The downfall with simply lancing the oral hematoma is, yes, it releases pressure and it releases the buildup of fluid. However, the animal, it will probably recur. So they're in the same boat. If the skin is not tacked back down to the cartilage, then it can recur. And that is it for non-neoplastic, non-inflammatory.